Hi, everyone. I'm Vidya. I'm a volunteer with Fertility Matters, and I'm here with Dr. Niamh Tallon from Olive Fertility Center in British Columbia. Thank you so much for joining us today, Dr. Tallon. I almost said your full name, Dr. Niamh Tallon.
Well, thank you for having me. I love doing this, so it's a pleasure.
Great. As everyone knows who's watching, it's Canadian Infertility Awareness Week this week, and all week long we're bringing you content featuring different professionals in the field, talking about the medical stuff, the mental health stuff, the emotional stuff, all of the stuff that you need to know to help you along your fertility journey. So today, we are talking all about egg freezing, and Dr. Tallon will give us an overview of egg freezing, and we have a couple of questions for you, Dr. Tallon. So why don't we get started? I believe you have a presentation you want to share. I will mute myself, you go ahead, and I will chime in when the moment strikes.
Yeah. So this is to keep us on track and make sure we touch all the really important pieces of egg freezing as a reproductive option for women today and individuals today. So can you see that okay, Vidya? The screen is coming across okay?
Yes, it's up and it looks good. There's a cracked egg.
That's it. So we try to prevent those from happening. So we're going to talk about age-related infertility as a side of this, which is one piece of egg freezing. And then the other part is egg freezing for oncofertility as a big part of things. It's become a really big prevention strategy against like our anticipated loss of eggs or anticipated gamete exhaustion. And whether that's from, again, age or chemo, whatever, inciting events, surgery, potentially, egg freezing has become a really viable option. So we're going to go through the detailed indications, the process of freezing, and then some of the limitations of the actual treatment. So as we know, Canadian women are waiting longer to have children, and the average age of first births is like 29 now in Canada. And if you look at the provinces across, we're pretty close in terms of the age distribution before we start having children, but certainly the Northern Territories being the youngest. What that means is we see infertility rates by age going up with advancing age. It's harder to get pregnant when we're using older eggs, with an all-comer rate of infertility for anybody being like about 15-16%, but it can go as high as 64% when we're in our early 40s. So what that means is if you start later having children and it's harder, you're going to have less. And so overall, we see family sizes getting smaller with time. So you can see here in 1959, the average family size was 4 children. And in 2019, it was close to maybe 1 or 2 for most people. So one of the guidelines that's out there to try and address this issue for women is from the SOGC, the Society of Obstetrics and Gynecology. And they're saying that GPs, nursing practitioners, any doctor that really has an encounter with a woman in her 20s and 30s should really be bringing up age-related risks of infertility, and that we should be talking to women about why natural fertility declines and why success rates become lower with assisted reproductive technologies such as IVF when you're using your own eggs. Egg donation or using frozen eggs from younger women is the only intervention that doesn't really change with time. And if we look at why treatments decline with advancing age, it's really because we're born with all of our eggs as women and we lose them as we get older. And as we lose the total number, they also accrue some background abnormalities, which make them less likely to bring a healthy embryo or a healthy ongoing pregnancy. And you can see that really like in the later 30s, this starts to decline significantly, and then you start to see changes in fertility. And late signs are like menopause or irregular cycles like perimenopause. It becomes really hard to get pregnant when you're starting to see critical loss of egg number, and a lot of the remaining eggs tend to be abnormal.
Dr. Tallon, I have a question. You said that there's an increasing abnormalities as the eggs become older. What are those abnormalities, or do we not know?
We do know. So the machinery of the egg is really important when you look at the role it carries in fertilization. So when a sperm enters an egg, the machinery or the spindle apparatus of the egg needs to sort the chromosomal material, so the genetic material from the sperm and the egg. And it has to sort that information. Sorry, I'm on a fast forward here. It looks like I'm just going to pause my presentation. So we were saying the abnormalities within the eggs and embryos result from mismatched sorting of chromosomes that you see from the sperm and the egg. And then as a consequence of that, you end up with embryos that just aren't consistent with bringing an ongoing live birth for the most part. So we do know that those errors, we call them meiotic errors, increase in frequency, but also not just frequency or how commonly they occur, the number of abnormalities increase within a given egg or embryo with advancing age. Okay. So I'm going to go back a step and I'm just going to fly through here. You'll see we were saying, so why is it of concern really if women are leaving a little bit later? Well, those abnormalities give us a higher chance of infertility and a lower chance of ongoing pregnancy. But you'll see here that it's not that necessarily women want to leave it till later. Some will, but the biggest reason is actually we haven't met a partner in a timely way. And big studies have shown this, that really this is one of the issues that's facing women now, is that they just haven't met the right match to even have a family with. So where does that leave us? So what are our options when we are aware and we've been made aware by a consultation or a discussion with a family doctor or a gynecologist or fertility specialist? What are you going to do about knowing that your age has an important piece to play and that eventually we can run out of our gametes or eggs? So this is our anticipated gamete exhaustion. Well, you could choose to get pregnant now without a partner. Or with a partner. You just prioritize that in life. If you don't have a partner, there are options in terms of using donor sperm, and that can be anonymous or known now. You could wait. You just deal with things as they arise. Wait till your ducks are in a row, and if at some point in the future you don't find success, and you can consider fertility assistance then. And potentially what you're looking at is if your own eggs are older, you may need more treatment cycles to find success, or potentially you maybe are looking at using donor eggs. And some accept those age-related limitations and look at smaller family size as a consequence of taking that approach. And for women who are over 45, really IVF with their own eggs or pregnancy with their own eggs doesn't really yield great success. So their best step forward is usually using donor eggs from younger women, or if they had frozen their own eggs at a different point in time, they could potentially thaw those eggs and use them. Adoption is something that can be an option, or child-free living, fostering, all alternative options to consider in the bigger picture. So a lot of women today are aware of all of this, and they say, you know what, I actually want to freeze my eggs today and safeguard them for potential later use in life. And this is becoming really common. So egg freezing for non-medical reasons has increased significantly since 2013. And I just had a look at the most recent data, like the 2019 numbers really show that egg freezing cycles in Canada last year surpassed 600, which is a big jump for us. So it's definitely a very viable option, but for everything that we can offer, there's potentially a downside, and you need to be aware of what the limitations of anything we're offering. So why are there freezing hazards, and why has egg freezing not been always at the top of the list? It's really because the egg is a big cell and it's full of fluid. And as that fluid-filled structure, it's at risk of ice crystal damage, freezing and thawing. And so really the technology has been honed over the years and became really valid in 2015, where success rates having used fresh or frozen eggs became comparable. And as soon as we could see pregnancy rates were really reasonable, well, then it was being offered through fertility clinics as a viable option for all applications or indications. So the elective piece, this elective egg freezing option, is really where we're talking about freezing eggs for women to extend their fertility beyond what you would expect from just their age. Okay. And this is certainly the more common reason we're seeing patients show up for egg freezing now. I would say egg freezing is an option that could allow women to extend their fertility. It's not a guarantee, and that's a really important piece with the counseling, is to understand that it's not really a guarantee, but somewhat of an insurance policy. So applications, clearly cancer patients who are about to embark upon sterilizing treatments like chemotherapy or surgery that would remove their ovaries. Egg freezing treatments prior to that would give them the opportunity to safeguard some eggs for potential future use when they're on the other side of treatment. Or for individuals who are considering perhaps going through transitioning with testosterone, it would be an opportunity and a time for them to potentially consider safeguarding some eggs. Women who donate eggs in the USA to egg banks for greater distribution go through the process of fresh IVF or the process of stimulation and egg freezing cycles to retrieve eggs and for freezing and distribution as frozen eggs. There is religious reasons for the countries and some patients who have strong beliefs against freezing embryos or supernumerary embryos and would feel better about having eggs frozen as opposed to embryos. In some emergent settings, for example, when there's a couple going through fertility treatment, and we're on the day of an egg retrieval, potentially there can be a man who gives a sample where there is no sperm. Now that's not very common, but because eggs live for 24 hours really beyond the point of retrieval, the opportunity is short-lived for what you're going to do with them. So egg freezing is an option if you don't have sperm available. And then for patients who are considered poor responders who don't have big yields of eggs from a treatment cycle, they sometimes would opt to freeze eggs in the event that they would just keep coming back to do more cycles. And when they had a bigger number, then they would thaw them and use them upfront for the next steps. So there's lots of applications that have really changed the field of fertility with this technology. And again, there's pros and cons to whether someone should go ahead with egg freezing. And this list is something that I go through with every consultation and every patient that I have that's considering her options for future fertility preservation. And sometimes I'm seeing women as part of a relationship where they just have discordant wishes. And the woman just says, you know, while we're working this out, I would like to do something proactively for myself and safeguard my younger eggs. So one of the big pros in this, as opposed to committing sperm to an egg and making an embryo, is if you freeze eggs, women have full ownership over that. You're not having to commit to the idea of where the sperm is coming from. So whether that's a donor or partner, you're theoretically putting aside your best quality eggs in your life. And it's considered pretty cost effective compared to doing treatment later on in life. If you compare having one, treatment cycle yield eggs from an under 35-year-old versus her coming back later in life and doing IVF cycle with her older eggs, she is going to need to do more treatment and ends up being more expensive. And potentially, we're talking about using frozen eggs for those who actually still get pregnant on their own later. It's not necessarily that a woman will only use them upfront for her first. She may get pregnant later on with a partner, but the older you are with that first child, always you have to think that it's going to be older when you have your second. So it may allow this opportunity for a second or a third child and growing family size. The downsides to this are you may never use those eggs. So if you didn't have the ideal situation that you need to allow you to thaw eggs and create a family, we see that about 10% of people never come back. We see there's obviously a cost to treatment. And the younger a woman freezes her eggs, the more motivated she is and the more she's on point with regards to her fertility, the less likely she really is to need them later on, because she's prioritizing this in her life. There's risks to the egg retrieval process. So bleeding, infection, damage to structures, they're all theoretical risks. We do see ovarian hyperstimulation syndrome as a side effect of taking the injectables to make eggs grow for retrieval. And it can lead to bloating and pelvic discomfort. The discomfort is mild in 20 to 30% of patients. I would say ovarian hyperstimulation syndrome is quite rare, and we see it in about 1% of all egg freezing cycles. But the biggest downside is no single treatment is going to guarantee anybody a live birth in the future. So we're going to go through that a little bit here. So the process of getting eggs to freeze requires the eggs to be stimulated by hormones. And usually this takes anywhere between 8 to 12 days of injectables. And everything begins with a menstrual cycle. So menstrual cycle, start injectables, usually twice a day, in an effort to signal to get those eggs to grow within the ovaries. And we are usually monitoring throughout those 8 to 12 days to get to the sweet spot where the eggs are suitable in terms of growth, where we're going to get viable eggs at an egg retrieval. The egg retrieval process is a vaginal procedure with an ultrasound probe in the vagina. It usually takes about 15 minutes. Women get what we call conscious sedation, so medications to make them calm and not have pain. And then it's really from there in the lab that we sift through all the fluid that we have aspirated from the ovaries. And within that fluid, we're looking for the eggs. And at that point, egg freezing takes place and the eggs are frozen for potential future use. And we freeze in liquid nitrogen. So it's a pretty quick process. Most people are going to work. It's normal life in those 10 to 12 days. The day of the egg retrieval is a day off work for sure. The big differences from what we see with stimulation for egg freezing and doing the procedure versus fresh IVF is that on the other side of thawing eggs, we know that not every egg is going to actually survive the freeze thaw process, but survival rates are still really good at 70 to 90%. And because of the process that we put the eggs through for freezing, we must inject a sperm into an egg to allow fertilization to take place later on. So in fresh IVF or in vitro fertilization, we can just put a droplet of sperm if sperm is of good quality and moving fast, and we can allow the sperm make their way into the egg themselves. So we call that standard fertilization. But for egg freezing patients, when you've thawed these eggs, you have to inject a sperm into an egg. And this is just really giving you a summary of what you see happen from the point of, this is an ultrasound image at the top. See this like chocolate chip cookie appearance? That's an ovary containing follicles, or the black sacs, and each follicle contains a single egg. And when we get to the point of egg retrieval, under the microscope, we're looking for a picture like this hazy fried egg, which is really what a mature oocyte looks like. And the yield from every egg that is, or every follicle that is drained from an ovary, the yield of eggs, mature eggs, is about 50 to 80%. And we would only freeze those that were mature. And then on the other side, we're saying there's survival of, somewhere between 80 to 90% of the total yield. We would then inject a sperm into an egg, and then we have to see how many of those fertilized eggs yield an embryo. And there is a drop off at every step of the way, and the attrition is well described. And we expect that you see something like 30 to 50% of the embryos would grow to a stage that would be suitable for use. Okay, and so either those embryos go back into the uterus for pregnancy, or we can sample them and do pre-implantation genetic testing, which is really just age-related chromosomal screening. So we're checking to see which embryos look like they're chromosomally most healthy from those eggs, and then we choose the best embryo to replace from there. So some patients will come to a consultation. They're under the impression that really, if you go through egg freezing, it changes the quality of your eggs and gives you a different kind of success rate in the future. It does not change the quality of your eggs. The idea is if you come in, you are safeguarding your best eggs yourself, but the impact of maternal age is always going to be there. So the patient who freezes her eggs at 33 has a much better outcome than the patient who freezes her eggs at 38, because there's already been some effects of age clearly between those two age groups. But we do see the success rates really mirror that with fresh cycles. So I want to look at some comparisons because I think this is really important. So when you consider how is egg quality affected over time? Well, if you look here, these three columns, there's young women under 35, those 35 to 38, and those 38 to 40 years of age. And what I've done is I've held the egg number that we've gotten at a treatment cycle stable across those age groups. And I'm giving you the projected live birth rate. If you were to thaw 10 eggs from an under 35-year-old, she's a 60% chance of getting a live birth, a single live birth from those 10 eggs. Whereas someone 35 to 38, even if she still gets 10 eggs, her live birth is lower because those eggs, again, are older. And the same pattern for 38 to 40-year-old at a 40% live birth rate with the same number of eggs. In reality, though, a given woman who gets 10 eggs under 35 is not going to get the same number of eggs when she's older in a treatment cycle, because we also lose our total number over time. I'm just trying to show you here, though, the effect of just quality over time, or the age-related effects on quality. In this comparison, we're going to look at like how egg number is affected over time. And what you see is under 35-year-olds, the average number of eggs we see come from an average 35-year-old would be about 10 to 15 eggs. At 35 to 38, it's 10 to 12 eggs, and 38 to 40-year-olds, 8 eggs. So these are average numbers we see for patients at these age groups, and you can see how just that alone affects the live birth rate. So we actually use statistics and modeling to give patients an overall projected likelihood that they might have a live birth based upon their age at the time of a consultation, or based upon the number of eggs they have. And this looks really busy. If you just look at what's the likelihood of having one baby, which is the blue lines in the graphs, if you look at a young woman at age 30 to 34, if she gets 10 eggs, her likelihood of a live birth is in and around 50%. 10 eggs, 60%. 10 eggs from a 35-year-old is 50%, 10 eggs from a 38 to 40-year-old, 35%, and again, so forth. 41 to 42, we don't see many 41 or 42-year-olds get 10 eggs, but if you did, you would have a 20% chance of at least one live birth. And within any group of eggs, there's always the potential that you have many good eggs that lead to viable embryos, and you could have more than one child. But you can see there's never 100% in these modeling projections. Even for a 30-year-old with 30 eggs from an IVF cycle, that you're not reaching 100% probability of a live birth. It just isn't going to be that way. There's always averages, and some people do better than others. And when we look at the most important points about egg freezing, is just to realize that the age of freezing and the number of eggs frozen really are what give you your best chance of success. And some patients do require more than one treatment cycle to accumulate eggs to reach their expectation, and there isn't a guarantee. And some of the tangible pieces that we want to give someone is how close can you get to knowing if you have enough eggs ahead of time or even after treatment. So we use some tests to help patients determine like expectations, like how many eggs do they think they're going to get? And we use ovarian reserve tests to estimate that ahead of time. And, you know, we're doing either blood work on the 3rd day of a menstrual cycle, and we're looking at a hormone FSH to project, you know, do they have a reasonable egg reserve, or do they look like they're perimenopausal or postmenopausal? The AMH test, that's the anti-Mullerian hormone test, is the single most important test in my practice for this kind of counseling, where we look to see what the hormonal value is to represent someone's own egg reserve or number of eggs that are remaining. And we use that to compare them to their peers at their age group. And if they're on par, you say, look, if you have a value that looks like an average 30-year-old and you're 30, that means you're going to look like and respond like the average 30-year-old. But if you have an AMH value that comes back that is reflective of the egg reserve of a 40-year-old, yet you are 30 years of age, that means you are not going to get the same number of eggs at a treatment cycle than the average 30-year-old. So we use those importantly to give projections to patients as to what they think they may get from a single treatment cycle. We do ultrasounds, so transvaginal ultrasounds to look at the ovaries, and we get a sense of how many little sacs or follicles are sitting in the ovaries at that time. We use those three tests really together to estimate the likelihood of getting eggs from someone. So these tests, again, are quantity, and we estimate the number of eggs that we think we get from a treatment cycle, and they can't tell you what's going to happen to those eggs in the future. You got to use them to work that out. But there are other technologies that we use to work out if your eggs are good or better quality than others. And that's really where this Violet technology comes in, which is AI imaging technology that really tries to score eggs against each other. And it looks at different features of the eggs prior to freezing to guesstimate a very high probability of fertilization and leading to an embryo. And it might help women determine better if they need to do more treatment cycles. So this is something that we offer in terms of giving women a step closer to really understanding whether the eggs frozen are going to bring them something. And the reports look something like this. It's a little complicated, but they get a result that says, you've X number of eggs frozen. So 10 mature eggs frozen here. And it has guesstimated the likelihood of making embryos, and an average of 4 to 7 embryos with a 50% probability. And then it gives a live birth rate estimate. So at least a live birth projected likelihood of 42%. And this is considered a little bit more accurate and individualized in terms of an approach than just using statistics that have been built based on big populations of patients. And a really common question we get from patients is, should I freeze eggs or embryos? Which is better? To me, they're very discordant. They have theoretical goals. With egg freezing and embryo freezing, like if you're looking at a committed couple that come to see you together and they are wanting to give themselves the best chance of safeguarding embryos for future use, I think embryos is the better way to go, because in real time what any eggs have been retrieved are going to lead to in terms of embryos and what those embryos are capable of bringing. You can also do genetic testing on embryos, but that's really where the couple have found each other and they're committed to the process. If I have a couple where they're discordant or they're unsure, often the woman will consider doing egg alone, because age is something that affects women, not necessarily men. And as a consequence, they're trying to have full ownership over their eggs while still bringing that possibility of using those eggs when they're at a later point in time. So I do see some single women opting to get pregnant now, pretty commonly when they've reached 38, 39. If they're more open to conceiving on their own, they'll get donor sperm and often, take it to the embryo level and then do genetic testing to screen out age-related chromosomal abnormalities. So if we look at what's the answer? Is egg freezing the answer for everyone? Not for everyone. I really think this is something that requires close consultation and consideration too. But for the cancer patient, egg freezing is absolutely a viable option if they're single or not in a relationship and they're looking to have full ownership over their gametes later on, so their eggs. For patients who have a low egg reserve, so they've been counseled because they've previously had an ovary removed, or they've had multiple surgeries on their ovary that has caused some damage and potentially early loss of their eggs, or if there's a family history of early menopause, it's pretty reasonable to consider safeguarding eggs for later on. And that's pretty common. So we get a lot of consultation sent to us our way from gynecologists who are performing these surgeries and are proactively discussing egg freezing with their patients. And then for any woman who's deferring childbearing over 40, it's reasonable to consider egg freezing. But really, once your eggs are already somewhat older, you need to understand that any eggs you freeze bring you a lower probability of bringing live birth later on. But I certainly have assisted women over 40 in freezing their eggs. And if you have a single woman who's open to sole parenting, so she's okay with getting pregnant, she's not looking to co-parent or have a partner to share the family building with, certainly reasonable to consider pregnancy now using donor sperm. Sometimes they split the process, they freeze eggs in the hopes that they meet someone later, and yet they try to get pregnant now using donor sperm. And then for couples wanting to defer pregnancy, I do talk to them about the potential benefits of having embryos and screening. But they really do need to understand ownership when there's a couple involved. Both giving sperm and eggs to creating embryos, both need to be on the same page as to whether or not those embryos get used. So that's kind of a snapshot of egg freezing. And I think it's important that as women, we understand that we have these options. I don't really counsel that egg freezing is a great option to defer childbearing. I think it's a great option if you've decided already you're going to defer childbearing. Again, like you should make that decision first. But it's certainly, because I do believe the best guarantee for a family comes with trying today, always. So, but I think the egg freezing technology is so valid for what it is now. Certainly seeing lots of women participating in this. So that's what I have. I'm going to come out of this.
That was so informative. I'm like thinking about how to freeze my eggs, and I'm done making my family. So very compelling arguments there, Dr. Tallon. I do have a couple of questions coming out of that.
Yeah.
We talk about, potentially freezing your eggs when you're younger and to have a family later in life. What's a safe amount of time to freeze eggs?
Yeah, we consider like any amount of time reasonable. So, for a woman who's freezing her eggs under 35 and she comes back 10 to 15 years later, we don't see like a yearly attrition in the success rates for the time that they're frozen. So women pay for storage per year. We often see that they will touch base with us over time when they have, they go away for a few years, come back, and often will ask questions like that, like, how long do I have? And I usually will say it's more an issue of, how old will you be when you're trying to get pregnant? So for example, we do embryo transfers from eggs that are either your own or donated up to the age of 50 in Canada. So the age cutoff is like 50 years. So you just want to keep that in mind. That's more because of health risks in terms of, being pregnant.
Great. And I know this from my own egg retrieval cycles, but how many egg retrievals would be needed or to get the ideal number of eggs to freeze?
Yeah, and that's a really, I think, individual goal or mark that needs to get hit. So, I don't usually counsel up front, you're going to need 3 or 4, stimulation cycles. I think it's more a matter of like, let's look at how you do in the first. Let's see what we get. We're trying to be aggressive and maximize the likelihood for success in one treatment cycle. But like you could see from that report, that when you know what you have, and you know how those eggs look under the microscope, and you know what your own projected probability is for a live birth from that you often as a woman will weigh up, well, is that good enough for me? And some feel just the act of having frozen some eggs is enough for them. They're not necessarily committed to getting like an 80 or 90% probability. They're just wanting to have something set aside in the event they need them. And there are others that are committed to a certain number of probability they want to hit. And so they will be open to multiple cycles. But we usually touch base multiple times over the treatment cycle and review where they're at to give them a sense of what they need to do. But the Violet report really helps with kind of framing, what your own eggs look like and what the probabilities are projected from there.
Yeah, that's a really great report. I feel like we have in embryos, and I don't even think that we got that. With that.
You can only get so close. Yeah.
You might have covered this and I might have missed it, but can you thaw eggs, inject sperm, or do ICSI and then freeze your embryos?
You sure can. Yes, you
can. Wow, that's so cool.
It is cool. So again, when we talk about survival rates, you need to realize like an egg is a single cellular entity. And again, like it just is more fragile than an embryo. When you've committed it to fertilization and it's growing and you have multiple cells in that embryo and they've started to separate into different cell lines that are going to represent different parts of a pregnancy, well, then it's more robust to any insult that it could sustain, like whether that's freezing or thawing. So embryo survival rates are like 99%, like 99.9%, like really, a lot of it has to do with the quality of the embryo. If you freeze a poor quality embryo, you're going to see lower survival rates. But if you freeze good quality embryos, you're going to see really high survival rates with them. But again, part of that is they're just more robust. They got more cells to allow further division beyond. Okay. So you can do both. Mm-hmm.
You can do both. And would you be able to do genetic testing on that embryo as well? Okay. Wow.
Yeah, you are. Yeah. So one scenario that comes up really commonly is a woman freezes her eggs earlier in life. She meets a partner. She then asks, she's like 41, say, and she says, should I thaw my eggs right away? Really, the idea is to use the eggs if you need them. How do you know that she needs them? She needs to try to get pregnant to establish whether or not she's going to have success, but that takes time. And then the question is, how much time should you give her, over 41? There's a big difference in success rates at IVF from a 41-year-old versus a 42-year-old and a 42-year-old and a 43-year-old. So time is really important. So one of the things I see patients doing, especially if they're open to more than one child, which most couples are at that point, is they're trying on their own, but in real time, they're thawing their eggs, they're creating embryos, and they're genetically testing them now to disclose at this point, is there a viable embryo in there to use? And they're frozen. And perhaps then they do have the best embryo in there, but they continue with their ongoing attempts to achieve a pregnancy. And they only come to use that embryo if they need to.
That's so smart. The options are really amazing right now to allow them to, pursue what they want to professionally or to find the right partner. Like, you don't have to feel, pressured necessarily into doing things before you're ready to do them. So that's awesome.
Yeah.
2 more questions. One, is egg freezing covered by the provincial health plans?
No, the actual fees for the services provided by the fertility clinic aren't covered. Clearly there's for onco fertility patients, so there's sometimes assistance for them in terms of coverage for treatment cycles, and we discount for those patients. So, they have the greater opportunity to go through, but for all comers, it's not covered. Sometimes the medications will be covered under an extended health plan.
Okay. And if someone wanted to pursue egg freezing, do they need a referral from their family doctor, or can they just call a clinic?
Yeah, in BC, we need a referral for the consultation to be covered by MSP. So that referral comes usually from a walk-in clinic, a GP, which is like so different now with COVID. Like you can do a virtual consultation so easily and just get that covered. So yes, we do need a referral for that. We see patients without MSP coverage and they just pay for the consultation.
Okay. That's it for my questions. Do you have any parting words for everyone watching?
Well, I have to say, I usually joke that my 12-year-old has no idea what's going to come down the line because I'm going to gift her this amazing thing one day. Having experienced, infertility myself and failed IVF cycles at the age of 38, going through years of education and everything else. And it was age related. I look at this as just being an amazing thing for women, but it's not for everyone. And I've told my 12-year-old that I share this and she's asked me to stop. Please don't tell people you're going to do that. But I think it's amazing for women. It's such an amazing, option.
Absolutely. Like, that's a great idea. If I had a daughter, I'd be thinking about that too.
Yeah. Safeguard grandchildren.
Yeah, exactly. Well, thank you so much for joining us today, Dr. Tallon. This was super informative. For everyone watching, I hope that you enjoyed this, and there's a lot of other educational videos and resources being posted to the Fertility Matters Facebook page this week for Canadian Infertility Awareness Week. So please check them out. And if you want to talk about egg freezing more, I believe Dr. Tallon's your woman. So thank you so much.
Thanks for having me.